All right, to move on with our program, I would like to invite our moderators for the next session, Dr. Shahbaz Mimon and Dr. Abdullah Jeffrey. Dr. Shahbaz, Pediatric Hematologist at King Abdulaziz Medical City of the National Guard, Riyadh, and Dr. Abdullah Jeffrey, who is a board member and Pediatric Hematologist and Transplant at King Faisal Specialist Hospital. Please, shukran.
Assalamu alaikum, good morning everybody, and you're all welcome to our meeting, the SSBMT and EBMT highlights. And I'm glad to share this session with my colleague, Dr. Shahbaz Mimon. And our first speaker is Dr. Mayada Abu Shanap. Dr. Mayada is a consultant pediatric hematologist oncologist and bone marrow transplant at King Hussein Cancer Center in Amman. She has been quite effective and active in terms of the publication and activities in the field of hematology and oncology in the pediatric side, hemoglobinopathies. She's going to talk to us today about rejuvenating the cord blood transplant. Please, Dr. Mayada.
Yeah. Assalamu alaikum jami'an, and good morning. Thanks a lot for the invitations. I will be talking today about rejuvenating the umbilical cord blood transplantations. I think the title is deliberate. So cord blood is not disappearing. It's repositioning to a new platform. It's moving from a backup donor stem cell source to a precision graft source for selected group of patients, and to a platform for an off-the-shelf cellular therapy. The outline of my presentation is going to be about milestone of umbilical cord blood transplantation, pros and cons, strategy to improve cord blood transplant without expansion, ex vivo expansion, adoptive cellular immunotherapy from the cord blood, regenerative medicine, some clinical trial, and future direction. As you know, in allogeneic bone marrow transplantation, matched sibling donor remains the gold standard, and when no HLA matched donor available, we have alternative donor. We are left by three options: match unrelated mod, umbilical cord blood, and haplo. In Europe and in United States, 1/3 of the patient has HLA match unrelated donor. In Middle East, I refer to a study published from King Hussein Cancer Center in 2013, where around 60% of the patients have match family donor. So we don't have match unrelated donor like in our ethnicity, or in some rare ethnicity group like African or ethnicity, we are left with umbilical cord blood and haplo, and my focus is about umbilical cord blood cell transplantation. As you know, the clinical experience and the history of cord blood go back to around 38 years of clinical experience, as the first cord blood transplant was for a kid with Fanconi anemia. He underwent a related cord blood transplant from his sibling, and this story, it was a success story because it showed the proof of concept that the cord blood contains a true and durable hematopoietic stem cell. In the early era of the cord blood transplant, many questions were raised regarding the engraftment, the stem cell dose, the GVHD, and whether the maternal T-cell contamination have any impact on the engraftment. And these questions were answered. Umbilical cord blood contained a sufficient number of hematopoietic stem cell and the progenitor to engraft. So they engraft, there is delay in the engraftment, but the engraftment is achievable. The immune reactivity and the GVHD less in the umbilical cord blood transplant, and the contamination with the maternal cell is irrelevant. Then in the era between 1998 and 2002, John Wagner's and Rubinstein's established two important basic, where is the engraftment, hematopoietic recovery, the TRM, and also the overall survival is cell dose dependent. And Wagner established a CD34 cell dose of 1.7 as the cutoff that correlate with a better outcome. HLA mismatch matter in the umbilical cord blood, but can be compensated by selecting a higher stem cell dose. Later on, there is a cobalt study. These are a prospective multi-institutional study. In this study, for unrelated cord blood transplant from 1999 to 2004, we learned a lot of messages that the greater tolerability of HLA match in pediatric leukemia transplant, and there was comparable survival to match unrelated donor. Also, the cord blood was readily available for patients with metabolic disorder and with also overall survival of 75%. And in non-TBI conditioning regimen post-cord blood infantile leukemia, we achieved a survival of 47%. But the transplant in the adult was hard because there was slow engraftment, high TRM, and high graft failure. So the takeaway from the old era is that cell dose, the TRM overall survival and engraftment is cell dose dependent, and HLA mismatch can be compensated and offset by selecting a higher stem cell dose, and these are the principles that we are still using nowadays. One of the landmark study in the cord blood transplant in pediatric leukemia in the children that published in Lancet in 2007, there was a comparable leukemia-free survival. What was important that if you select a match cord blood, 6 out of 6, the overall survival is 60%. So the cord blood no longer a second-line source. And in these patients who underwent the transplant with 6 out of 6 match, the chronic GVHD risk is low in these patients. It's around half in comparison with other stem cell source. So the bottleneck in the cord transplant is the stem cell dose. Experts in the transplant at University of Minnesota thought to override these obstacles by combining 2 cord blood. So the first double cord blood was transplant was established at the University of Minnesota. These patients achieved engraftment, and there was a good hematopoietic recovery with a good overall and leukemia-free survival. Then Wagner asked a question whether doing a double cord blood will have advantage of leukemia or overall survival in favor of single cord blood in children and adolescents with hematological malignancy. And in this prospective study, there was no difference in leukemia and overall survival between single and double cord blood, but there was trend toward lower relapse in patients underwent cord blood transplant, and also there was increased risk of extensive chronic GVHD. So we conclude that double cord blood transplant is a reasonable alternative if adequate single cord blood not available, and it expands the access to transplant in adolescent and adult with high weight and high size. So why I still use cord blood and for which disease? Major benefit and the advantage of the cord blood cell transplantation, more than 30 years experience. If you compare with the haplodonor, there is no risk of donor, reduced time to transplant. It's readily available and off-the-shelf cellular therapy product. Biological features, young hematopoietic stem cell, high capability of renewal, self-renewal, reproliferation, expansion, and longer telomere length. For which disease? The positive result most published in acute leukemia, ALL and AML, followed by pediatric immune deficiency and metabolic disease. Intermediate result in MDS, aplastic anemia, bone marrow failure, and poor result in hemoglobinopathy. So what some of the best transplant outcome reported in pediatric leukemia or in acute leukemia, even in adult? Why? Because cord blood transplant associated with decrease in risk of relapse. These patients have robust, durable graft versus leukemia effect. There is no HLA loss and less risk of relapse if we condition these patients without ATG. Look at this curve. You can see that umbilical cord blood had a better curves, chronic GVHD and leukemia-free survival in comparison with other stem cell source. So when we look at the, we should look at the patient, we should not look at the Kaplan-Meier curve. Our goal when we transplant our patient as transplantant, that these patients are alive, disease-free, and also GVHD-free. And you know how chronic GVHD impact the quality of life of these patients. And this is the favorable outcome because these patients who underwent cord blood transplant have lower risk of leukemia relapse and also lower risk of chronic GVHD. And one of the landmark studies that established that why a related cord has durable and robust graft versus leukemia effects This published by Milano and New England Journal of Medicine. When we transplant high-risk malignancy patient who underwent transplant with a positive MRD using the cord blood, the leukemia-free survival is higher in comparison with other alternative source. And this is the same finding in a high-risk relapsed refractory pediatric leukemia. This subcohort with a positive MRD have a favorable outcome and lower risk of relapse, and favorable also leukemia-free survival in comparison with the other stem cell source. Also, if we do double cord blood, this is French cohort, in comparison with a single cord blood in a cohort of patients with a positive MRD, the leukemia-free survival much better in this patient. And the last report from the EBMT for a subgroup of patients with adult high-risk acute myeloid leukemia who had positive MRDP transplant, the leukemia-free survival much lower in these patients. So what I mean by HLA loss? In HLA mismatch transplant like haplo, one of the mechanism of post-transplant relapse is loss of the HLA haplotype. And this could occur in a percentage of 20% in haplo, 11 in mismatch mod, 4% in mod, and 0 in umbilical cord blood. Why? In the umbilical cord blood, we have a mismatch, but these mismatch are not encoded, coded on the same chromosome cis. So this is decreased the likelihood that this patient will have this mechanism of relapse, the HLA loss, and to contribute to robust graft versus leukemia effect. Patients with cord blood have chronic GVHD but reduced risk, and the better GVHD treatment response as published in this ASH abstracts in comparison with the other stem cell source. We know that umbilical cord blood transplantation have delay in reconstitution in the first 100-day post-transplant, but they have in the first 60 days robust NK cell recovery. And also there is a delay in the B cell and T cell recovery till 100-day post-transplant. But what's unique, if we manipulate our conditioning regimen, if we omit ATG from the conditioning regimen in these patients, nowadays most of the heme malignancy transplant use fludarabine as a part of the conditioning, not ATG. Omitting ATG was associated with a favorable overall survival because it supports early reconstitution of the CD4 cell, and also in studies for pediatric transplant for heme malignancy, if we have a low ATG dose, this is support excellent T cell reconstitution and overall survival. So I can conclude that yes, immune reconstitution is delayed in the umbilical cord blood in the first 100 days, but it's different if we can manipulate our conditioning regimen and omit ATG. But what non-malignant conditions? Some of the best transplant outcome in non-malignant condition reported in metabolic immune deficiency and bone marrow failure syndrome. This is EURECORD data reported the largest cohort of pediatric transplanted for malignant and non-malignant condition. And as we can see, after 2019, there is a favorable outcome in all group in malignant and non-malignant disease. And I can go rapidly through this study. This is Heller syndrome outcome over years, metabolic disorder, adrenoleukodystrophy, ALD, also metachromatic leukodystrophy that's vaginal onset, a small cohort of patients with osteopetrosis, SCID patient primary immune deficiency, a favorable survival with 80%, familial HLH overall survival of 50%, Wiskott-Aldrich syndrome, small cohort of patients who used root conditioning in hemoglobinopathy disorder, and aplastic anemia, hereditary bone marrow failure syndrome, related cord blood, hereditary not Fanconi anemia have a related cord blood overall survival of 100%. Also, favorable survival in patients with Fanconi anemia. Related cord blood have advantage of survival in comparison with the unrelated cord blood. And this is the new cohort and the last data published for diamond black fan anemia for 30 patients transplanted. The related cord blood transplant in this cohort have a survival of around 100%. So the take-home message for malignant disease, we have a favorable outcome, but the tricky part is early referral of these patients to transplant, and then optimal selection of the dose and the HLA matching, optimal HLA match for this cord blood, and better supportive care in the early 100-day post-transplant. So what's the status of the cord blood transplant nowadays? It's declining. Yeah, this is the European data, and also CIBMTR data showed that cord blood declined, and there is increase in the haplotransplant and the match unrelated transplant in the last decade. And in USA, for example, 20% of the transplant center doing more than five cord blood transplants. So why the cord blood has declined? Because of the disadvantages, limitation of the cord blood that I will go through in a few minutes, and because of the competition. Emergence of the haplotransplant as alternative stem cell source with post-transplant time, it's easily in comparison with the cord blood. The limitation of the cord blood, as we know, lower cell dose, fixed cell dose, and there is no role for DLI if your patient relapse post-transplant, delay engraftment, delay in the immune reconstitution, higher risk of infection, higher TRM, and the cost of the acquisition of the cord blood definitely is higher than haplo. And then fewer trainee and staff gain experience in the cord blood transplant. So less experience, selection of suboptimal cord and suboptimal early post-transplant care, and this will increase the TRM. So to compare haplo versus cord, it's difficult because heterogeneity of the conditioning regimen method of the GVHD as prophylaxis, lack of prospective study, and lack of long-term follow-up in haplotransplant. I will go through 3 studies. One is prospective, and then 2 is retrospective study. In this landmark study, the BMT CTN 1101 study, they compare outcome of transplant in haplo versus double cord blood transplant in adult with heme malignancy. And in this study, they, after reconditioning, they found that haplo is favorable over umbilical cord blood in terms of overall survival because of the increase in TRM and double cord blood transplant. In pediatric, when they compare single cord blood versus haplo after MAC conditioning, Wagner reported a favorable and comparable leukemia and overall survival. And in this also study published recently in 2025 with the EBMT group in pediatric with AML, in this retrospective comparison, there was a comparable leukemia-free survival, overall survival, and but in the umbilical cord blood transplant recipient, if we compare haplo versus single cord blood, there is lower risk of chronic GVHD in umbilical cord blood, 7% versus 19% in haplo transplant. So in summary, each donor type carries advantage and disadvantage. Not enough data to support the use of one donor type over another. Recent data shows improvement in leukemia-free survival for both haplo and the cord. Donor choice is based on donor availability, institutional preference, urgency, donor age, size, disease risk, quality of the stem cell product, and the product access. A reduction of the mortality after umbilical cord blood transplant has been a landmark in multiple published studies because of improvement of the supportive care. And also, this is also another study showed there is improvement in the overall survival and the reduction in the mortality after umbilical cord blood transplantation. So how we reach this outcome? We worked on multiple strategies to reduce the mortality in the cord blood, summarizing by early donor search if we do not have HLA matched donor, optimize the unit selection, optimize the conditioning regimen in our patient if he had comorbid condition, optimize the processing of the cord blood at day 0, the thawing and the post-thaw quality, optimize GVHD prophylaxis and the post-transplant supportive care in the first 100 days. And there is published guideline how to guide us in doing all of these in the early post-transplant period, how to select, how to support these patients in the first 100. Post-transplant, CMV prophylaxis, avoidance of ATG in conditioning regimen, reduced ablative but intermediate intensity conditioning, triosulfan-based conditioning, for example, optimize the GVHD prophylaxis in patient single versus double by following the cyclosporin level and also CellCept. So, as I mentioned, the bottleneck in the cord blood transplant is the stem cell dose. So we override this in the adult patient, in adolescent, by infusing 2 cords of blood. But there is another method that is ex vivo expansion. In the ex vivo expansion, they use different platform to expand the CD34 from 10 to 300 fold. There is 3 platforms for the cord blood expansion and 3 clinical trials published. I will go briefly through this trial because there is a session about cord blood expansion in heme malignancy afternoon. This phase 1 trial by Wagner about the product of MGTA. In this product, the goal was shorten the time to engraftment, and they achieve a median ANC engraftment after 15 days and the platelet engraftment at 49 days. And this graph showed the shorter duration of engraftment time to engraftment in comparison with the other stem cell source. The expanded also Canadian cord blood, the UM171, also showed a short time to engraftment in comparison with conventional cord blood. And also in this study, they showed a favorable overall event-free survival and chronic GVHD using expanded cord blood, the UM171 product. And there was lower incidence of bacterial and viral infection. The omidubicil achieved also FDA approval 2 years ago for a patient with heme malignancy, and there was short time to neutrophil engraftment in comparison with the control, and rapid also platelet recovery, and reduced total hospitalization after in the first 100-day post-transplant, and significantly lower risk of serious infection as well as comparable overall survival to other stem cell source. As I mentioned in the introduction of my presentation, cord blood is not disappearing, it's changing. So it's repositioning to a new to a new platform, the adoptive immune therapy. The cord blood is attractive as a platform for cellular immune therapy because of naive immune phenotype, lower GVHD risk, banking infrastructure availability, and ability to generate monthly doses from a single cord blood. This is the platform for cord blood transplant. Cord blood can be a source for CAR NK cell for lymphoid and hematological malignancy, using an NK cell or T cell as a source for CAR. Treg also used, and MSCs can be used for cellular therapy, and also we can derive from the cord blood viral specific T cell.
You have 1 minute, Doctora.
Okay. So these are the adoptive immunotherapy in the cord blood transplant. These are clinical trial, and in ASH 25 there was a favorable outcome and favorable leukemia-free survival in the patient using these adoptive immunotherapy, as I mentioned. Finally, regenerative medicine, also there is multiple clinical trial using a cord blood as a stem cell source in the regenerative medicine. So should we keep cord blood transplant alive? As we can see, it's a balance. In the cord blood, there is higher risk of TRM, lower risk of relapse, lower rate of chronic GVHD, and long-term complication, lower in comparison with the other stem cell source. So the take-home message is high-quality stem cell source, major improvement has been achieved. Cord blood is a good for leukemia. Cord blood needs simple, cost-effective, innovative means to compete for haplo. And the final choice of the stem cell source is depend on the expertise, disease size, and product access. And thanks for your attention. I would like to thank the mothers and their baby for generous donation, and also I would like to thank dedicated staff and cord blood bank for their work. Thank you very much.
Thank you very much, Dr. Mayada. This is very comprehensive and comparative illustration between the haplo and cord and the potential of cord blood. I think we have time for 2 questions. Doctor, how do you see, within the Dr. Mayada, how do you see the role? The cord blood became, especially I'm talking about the pediatric field, it's sort of, and as you mentioned, the disadvantages of cord blood, and
yeah.
All of us lived the transplant of cord blood, and then the coming of the haplo transplants, and sort of it's becoming an easy way to transplant these patients. Are you, rejuvenating the cord blood? Are you now in the way to do cord blood, or is there any practical way to expand these cord bloods, let's say in our countries?
So, yeah. So the challenge, as I mentioned, the bottleneck is the stem cell dose, and it's challenging for adults more than in pediatric. In pediatric, we easily can find a single cord blood, and even if it is 5 out of 6 or 8 out of 10 matched, the outcome is favorable. And there is also some data about some mismatch associated with the lower risk of relapse and GVL effect. So the challenge is how to get this technology in-house and have this expanded cord blood in-house in our country. But I don't think it's going to be very challenging, because we are doing now CAR T cell in Middle East. So we need a GMP facility. We need to introduce this clinical trial expanded cord blood for our cohort. As I mentioned, there is a group of patients, they can benefit from the cord blood. These patients with high-risk malignancy. And the outcome in these patients favorable in comparison with other stem cell sources. Also, the chronic GVHD lower in these patients. And the most important things, cord blood can be a platform for the off-the-shelf cellular therapy. If we extract the T cell and the NK cell from the cord blood for CAR T cell. As you know, one of the challenging in the CAR T cell nowadays is exhaustions. So using T cell from the cord blood or the NK cell can be used to override one of these obstacles for CAR T cell. So there is a future for CAR T cell, is cellular immune therapy. So I think it's challenging, but as we in Middle East, in Jordan or at Saudi Arabia started the CAR T cell program, we can innovate and expand the use of the CAR T cell as the platform for cellular therapy.
Thank you. Yeah,
Thank
Dr.
you so much,
Shahbaz.
Dr. Mayada. Excellent talk. What do you see in pediatrics? What are the strong indications we should look for cord on top of searching haplo and mud and other possible options in the current era, where we stand?
In the current era, if the cord blood is readily available for your patient with high-risk leukemia, like patient high-risk malignancy with a positive MRD, I would go for cord blood. In patients with primary immune deficiency and also in patients with metabolic disorder, these are the three main indications that I would favor cord over haplotransplant. But by the end, I mentioned it depends on center expertise. It depends also of the availability of the cord blood. If your patient in remission and you do not wait till cord blood is shipped to your country, you can do haplotransplant for the patient. But in Jordan, for example, still we are doing haplo more than cord. The last cord blood transplant we did for a baby from Gaza. She was evacuated with her grandmother, and her grandmother was not matched for her. So we chipped for her and related cord blood. She has high-risk leukemia AML, and she's now 2 years alive and continuous complete CR after transplant. Still, there is a room to do transplant in patient with pediatric patient with leukemia. And as I mentioned, we compare single cord blood versus haplo, even if there is overall survival, leukemia-free survival comparable, but the chronic GVHD is lower in cord blood in comparison with haplo.
Thank you very much. Thank you.
Yeah. Thank you.
Thank you so much.